Please pop any questions in the chat box. We will invite questions towards the end of the presentation, where hopefully we've got plenty of time for discussion. We're joined today by colleagues from England, Wales and Northern Ireland, so welcome to you all. Colleagues are joining us from different settings, be it clinical or non-clinical, ICB, hospice, so you are very welcome. And just to mention that the presentation today will draw on the data tool that we use called the Data and Improvement tool. You do need a login to access this tool. Some of you will not have that as yet, and if it's something that you wish to have, then please just access our website and you can follow the links to request a login for the Data and Improvement tool. Next slide, please. So this is what our agenda looks like for this afternoon. I'm going to just give you a few brief updates about the NACEL programme, and then Rosie is going to take you through NACEL data and how you can use it to support quality improvement work around hydration. And then we're very fortunate to be joined today by two case studies.
Can't hear them.
If you could all please just put yourselves on mute, thank you. Two case studies are joining us today. So Ansgar is joining us from, sorry, I forgot to Anchor where you were joining us from North Middlesex, apologies. Anchor is joining us from North Middlesex and is going to give us an overview of their longest standing quality improvement project around hydration. And Paula Parr is joining us from Manchester and is talking to us about the work that they've been doing around hydration. And then, as I said, at the end, hopefully there'll be plenty of time for questions before we close at 1 o'clock. Next slide, please. So I just wanted to give you some updates about the NACEL programme. The next slide. In terms of participation, we are well into 2025 now. Looking back on 2024, you can see that we have had an incredible amount of participation. The green blocks are data from 2022 and the blue blocks are data that's been collected from 2024. And so we have captured over 250,000 deaths a year in England and Wales, which is a huge level of data completeness. That means that we are able to give a better representation about what's happening locally and nationally, and it also means through your incredible efforts that we are able to partake in conversations at high levels, such as the 10-year plan from the government and other palliative and end-of-life care discussions. So the data that you are collecting means that your voice is being heard around really important strategic conversations and support for palliative and end-of-life care. Next slide, please. In terms of engagement, there's been a great level of engagement for the quality improvement webinars. We've had over 250 attendees so far. We have 641 users of the data and improvement tool, and that number is growing all the time, which is fantastic. We've had nearly 150 attendees come to the drop-in sessions for the data and improvement tool. And so overall, we're seeing of the 99% of organisations that are partaking in NACEL, 65% are engaging with quality improvement webinars. So at this point, could I please just ask you to access the QR code or click on the link there. This is the evaluation form for today's session. We are very grateful for any feedback that we get, and we really do act upon your feedback. The last feedback that we had in October was around creating some templates for people to use when they're doing their reports, and you'll see in a minute that we have done that and uploaded those onto our website. So if there is any feedback about today's session or about the quality improvement webinars in general, then we are really, really grateful to hear from you. Thank you. Next slide, please. So in terms of the quality improvement offer, there's the webinars, there is the data and improvement drop-in sessions, but there's also a few other resources on our website. So this page is the quality improvement pages from the NACEL website. And this section is the document section. I just wanted to draw your attention to two bits on this page. So the first is the reporting templates that I just mentioned. Some of you will be doing reports as it's coming to the end of the financial year. There are 4 examples taken from trusts across England and Wales of reports that they have done, which have been anonymised. Those reports are up there as templates for you to download and edit, and hopefully they are really helpful for you. If there's anything else you feel should be up there as a template, then please do just drop us an email and we would be really happy to upload that. The second highlighted bit is the mapping documents. The mapping documents is a document which has every single bit of NACEL question on it, and we map it to the primary driver that we use in NACEL, aligned with the primary and the secondary driver for that question. We've put that up there to help you with quality improvement work, and so hopefully that will help you identify the aim of your work and help you align different questions from NACEL that could be used to support or measure the quality improvement intervention that you may be putting in place. Next slide, please. And then a reminder of how to use NACEL data for quality improvement. Many of you will be very familiar with this diagram, which is the 6 stages of quality improvement taken from the Institute of Healthcare Improvement. And if you go to the next slide, what we've done is break that 6 stages down on our website, and we have uploaded some tools, some templates and some diagrams to help support you through each stage of quality improvement. Next slide, please. But why we're here today is to talk about hydration, and the NICE quality standards in 2017 outlined that adults in the last days of life should have their hydration status assessed daily and have a discussion about the risks and benefits of hydration options. Next slide, please. So how that fits with NACEL in our 10 key areas, or our 10 primary drivers, is this one highlighted in red, which is the plan and do section of NACEL and individualized management of symptoms. So hydration fits into that primary driver for the NACEL driver diagram. Next slide, please. And on that mapping document that I spoke about, these are the 5 questions that will support you to understand what hydration looks like for your hospital and help support or measure quality improvement interventions that you're putting in place to improve hydration. So there's 3 questions there that are taken from the case note review. There's 1 question from the quality survey, now known as the bereavement survey, and there is 1 question from the staff reported measure. So 5 questions triangulated from 3 different sources of NACEL data collection, and you can see there how they align to the secondary driver and the primary driver of individualized management of symptoms. Next slide, please. So on that note, I'm going to hand you over to Rosie, who's going to talk you through understanding your NACEL data about hydration. Thank you, Rosie.
Hi, everybody. So just recapping from what Jess has said, NACEL can really help you with understanding your hospital position about hydration and providing some ways of systematically monitoring that. So I'm going to talk through in a short video in a moment the NACEL data from 2024 and show you what that's showing about hydration within our hospitals in England, Wales and Northern Ireland at the moment. We know that from families and from the NICE guidance that this continues to be an area that we need to all think about our own practice, and many places still have a lot of room for improvement. Really importantly, after we've had a little look at what the data is showing, there's the case examples, and I think that's what will be really important today, to hear about how people are working in practice using NACEL data and other sources to try and make a difference to improving this in their hospitals. So we'll now just go through the video which looks at how to the data itself. Just a reminder, if you don't have access to the data improvement tool, please do register so that you can look at your own data and help those in your hospital and all of people involved in improving things. Thank you. And the next slide will be the video. Hi, I'm Rosie Bonnet and I'm the Quality Improvement Clinical Advisor for NACEL, and I'm going to show you some of the information on the NACEL dashboards around individualised management of symptoms. And I'm just sharing the screen logged into the NACEL Data Improvement tool. As a reminder, there are a dashboard view and an overview. The dashboard view now has the data all the way up to January 2025, so all of the NACEL 2024 data for you to be able to review and download. There is a new section which is a key indicator summary, and then the individual sections by the driver. So I'm not going to share this information to protect each individual organisation's data for themselves, and so we're going to focus on the overview section, and I'm going to be sharing the national results. So here I've selected NHS benchmarking as the organisational submission, which looks at things overall. When you select your organisation, your data will come below here as a submission. So the information about hydration options sits in the plan and do section under individualised management of symptoms. And if you scroll down, you will find there's a whole section here about our questions related to hydration and nutrition, with the hydration options we're focusing on today. So you can see that around 67% of people who died had a daily assessment of their hydration options. Communication with the patient themselves was variable, with the most common option being that there was no communication, but there was a reason recorded why not. Communication about hydration with those important to the dying person was mixed, with 35% of cases having a comprehensive communication and a bigger proportion having no communication and no reason recorded why not. In the staff reported measure, which remember focuses on staff who deal commonly with people who die, there was a relatively high degree of confidence that they did understand how to discuss hydration options, and it will be helpful for you to think about whether that represents your staff groups overall in the hospital. And then lastly, this is from the bereaved families themselves, about whether they thought that the person had enough support to drink or receive fluids if they wished. And these are, again, interesting ones for you to look at and think about with the different filters. So there's many different filters that you might want to look at. You may want to check these by some of your equity markers, such as ethnicity, or you may want to look at, for instance, whether an individualised plan of care in an individualised plan of care template or document itself makes a difference. So you would be unable to check that against the quality survey information. But for example, in the section that talks about communications with relatives, we see that having an individualised plan of care does improve from around 35% to 45% comprehensive communication. And so that these information filters might help you to be able to think about some of the quality improvement areas, whether it's assessment, communication, staff confidence, education, that might be the first areas for you to concentrate on if you're considering quality improvement initiatives in this area. Thank you. Next slide. So now we're going to get on to the really interesting bit, hearing about people who have tried to improve the quality of these areas in their day-to-day work. So I'm pleased to introduce Antka, who's going to share the work that she's been doing at North Middlesex. Thank you very much, Antka.
Thanks, Rosie, for the introduction. Yeah, I'm Antika Hagener, one of the consultants in palliative care at North Middlesex. And just first, it's not me who's been doing it, it's been a whole group. I'm just the longest standing member. So what we were asked to talk about is how what we've done, what QI projects we've done, how we use data to support it, how we use NACEL data and individual data, what has enabled us, and what were the challenges. Next slide, please. So in 2019, we did, as always, the NACEL audit, and were not particularly pleased with the outcomes for ensuring the dying person is supported to eat and drink if they're able and wish to do so. And that's thanks for clicking. Those were the results. So we had 37% when that was recorded. We said we have to do something about this. At that point, obviously, there was no staff questionnaire in NACEL, so we did one and sent out to medics, nursing, and allied healthcare professionals. And it was interesting because the outcome showed that in all of the staff groups, there were lots of people with very detailed knowledge, but the confidence that they reported was really low. And it results in a lack of a culture of supporting eating and drinking at the end of life. And just a brief side explanation. So North Middlesex Hospital is a hospital in Northeast London. We have a very culturally diverse population with a low deprivation index. And for example, in one of our boroughs in Haringey, there are on ONS 180 different languages spoken, and about 30% of the population have English not as their first language. And that's reflected also in our staff, who often come from the same in-reach zone, which means that there were not just language barriers, but also cultural differences in approaching end of life, and particularly the very, very emotionally burdened questions of eating and drinking. And yeah, so our action plan in 2020 was to start a workshop with palliative care dietitians and speech and language therapists. We developed bespoke training suites for nursing staff first, and then for medics, and then one to use for multidisciplinary teaching sessions. We also said there needs, because of the confidence, there needs to be a referral option. So there need to be a clear pathway to ask for help. So there's a referral option to salts and dietitians for eating and drinking and end of life. And they also developed a bedside sign, hydration nutrition for comfort. And I show that on the next sign. We, after each QIP cycle, after PDSA cycle, we checked, that's the last slide, I think the next slide. Yeah, thanks. So that's the bedside sign that we developed. After we rolled that out and did our teaching sessions, it showed improved staff, not just competence, but also confidence in approaching these discussions. And as you can see, you might have read through it, it gives advice, not just for the nursing staff, but also for the relatives of carers to refer to, so that we're saying we really would like to support your loved one to have something by mouth, have something naturally, but these are the warning signs. Next slide. That was QIP number 1. And if you click again, so we then said, let's make a working group on hydration and nutrition at the end of life. And so the initial working group stayed on. We developed this driver diagram, which said, so okay, there are clear staff components, there are clear patient components, and later on we identified some other practical issues. The staff components I've already mentioned, it's competence, but also confidence or awareness of support. For the patient linked components, there is a need for clear communication and including a record of these. There should be regular reviews, and staff should be able to address questions whatever they might be. Staff needs to be aware of potential cultural or religious needs, and we need to address the language barrier. Ideally, patients and families should have written information so that the people who are in the hospital can take it away, ponder over it, or share it with others. And we also wanted to include local communities' views in end-of-life care planning. So on the right-hand side, you see the light blue was the QIP that I've just talked about. In parallel, and I haven't written about this here, we had another large QIP at the time called Bridging the Gap, where we did focus group meetings with local cultural groups and staff workshops to explore a broader, not just hydration nutrition issues, but the whole end-of-life care needs for different cultural groups. But now, so just to say, I'm not talking about the right column. The last two bits are not correct, but in the slides that are going to be sent out, they'll be corrected. Next slide. So this is then what happened next. And as you can see, it's not just a quality improvement, but it's sort of a quality control. It's become into quality control activities. And as I said, there was a working group established, which is ongoing. QIP number 1 I've talked about. And if you just click again, QIP number 2, at the next stage, we said, okay, we really would like to improve the discussions that are happening, and very simple PDSA cycle. Next click. We adjusted our end-of-life care plan pro forma. At that time, it was on paper. By now, we're electronic. And if you click again, so on there, the question that initially had just been planned for hydration nutrition, we now give a few more triggers in what we'd like to discuss, as in risks and benefits of artificial nutrition and hydration, and how to support natural oral intake, again, with the link to potential referral to SALT dietitians and the use of the bedside sign. Next slide. If you click again, so next is the QIP number 3. After we've focused on staff and what we can do on our side, we said, okay, we also have to think about carer education. How can we share what we're repeatedly saying? How can we share that in a reproducible form? And so in each of these QIP cycles, it always included staff training, medical nursing, allied healthcare professionals. Next slide. So what we did, we have a Care in the Last Days of Life leaflet. And if you click again, it talks about all the changes. Yeah, thank you. It talks about all the changes at the end of life, but we redesigned the whole paper, the whole leaflet, but in particular the paragraphs on food and drink. Please read it through, or it'll be in your pack. But what we've addressed here is first just general changes. Secondly, benefits and risks of clinically assisted hydration, mostly hydration. And the last one is how to support oral intake even in the last days of life. I mentioned the language issues. So because we have such a huge variety of languages spoken, we don't have just a large Gujarati community or 1 or 2 languages that are predominantly used. So it's not easy for us in our trust to have patient information leaflets just translated in the top 5 languages. We have small frequency, but a large range. So we just opted for very simple English that's easy to understand and easy to translate by professional and lay translators. Next slide. And that comes to the last QIP, if you press. So I didn't mention, but every year, as the twice in between, our NACEL ratings, our NACEL outcomes for hydration nutrition had improved. And in the last one, so in the one 2024, we looked at the 6 months data, so from quarter 2 and 3, and looked at the staff questionnaire. And that was, yeah, anyhow, looked at feedback we got there, and we saw that we still have quite a high number of where the communication that's documented is not comprehensive but only partial. So using the preliminary data from last year, we said, okay, let's look. You can already click on the next slide. Let's look more specifically at patients, and Rosie, you just mentioned that, patients who have an individualized care plan in place. And then let's look at an area where they're probably good at doing this, and look at all our care of the elderly wards. So this is a poster that we presented in November to our improvement fair. And next slide. This is what we did specifically. So as I said, we looked at patients on the care of the elderly wards who had an individualized plan for end-of-life care in place, did a 2-month data collection and reviewed the nutrition hydration part. And we checked A, is the nutrition hydration part completed? B, is it completed adequately? So what NACEL says, comprehensively, as in, did it really discuss the specific needs of these patients at the end of life, benefits and risks of clinically assisted hydration nutrition, and comfort in eating and drinking if appropriate? Third question was, is the patient's nurse aware of the plan? And 4, you might remember our bedside sign from the first cycle, is the relevant bedside sign up? Now, drum roll, next slide. On the right, you can see the outcomes, pre and post intervention. So pre-intervention, sadly, but maybe not surprisingly, the bedside sign was used in none of the cases. So 100% no, unfortunately. We did the usual intervention. There was a teaching session for medics. There's also an update for the end-of-life care champions on the wards, and a short teaching session for the ward managers. And we went around in an advertising campaign with newly printed out bedside signs. And at least it went to, let's call it, nearly 50%, went up a bit. Next slide. What I'm trying to say is that, so there's no rocket science. We didn't do anything that you will be doing all of these things, but it has been really helpful to have the NACEL data. The NACEL data that has become more detailed, especially about hydration nutrition, including the staff surveys. But we've enhanced that with local data collections. And it wouldn't have been possible without a committed workforce. If you click again, a big thank you to our longest standing contributors to the work group, Carla and Victoria. But also you see a list of junior doctors and nurses who came, and they often go again, so they obviously rotate, who all came in with fresh energy and fresh will to improve what we can improve or to maintain the quality that we've already have in place. So the big challenge is really sustainability due to staff turnover, and things get forgotten. So we've got a beautiful improvement bit item like the bedside chart, it gets forgotten. So what can we do differently? I've learned from the previous, so I had a preview of the slides. I've already looked at the sustainability score. So we're going to use that from the NACEL website. Thank you very much for offering all the QIP tools there. And what we said, to maintain or create more of a culture, we need both sides. We need the ward level, and that's the ward end-of-life care champions, and we need trust leaders to effect, hopefully over time, a culture change for this. Thank you very much.
Thank you so much, Anka. It's such a comprehensive presentation, and what I really loved about it when we spoke all those months ago was how relatable your quality improvement work is. As you say, it's not rocket science, but for many people it's so difficult to implement. But hopefully it's something that others can relate to and can see the benefit of. And I also really like your honesty about the challenges that you faced. So thank you, and we will invite questions after the next presentation, which is by Paula Parr. Welcome, Paula. Paula has a wonderfully unique role in Manchester as Head of Nursing in Palliative and End-of-Life Care. And I'll hand over to Paula. Thank you.
Hi, everybody. Yes, thank you for having me. So I guess if we move on to the first slide. So Manchester Foundation Trust, it is the largest NHS trust in the country, and we've focused for NACEL, we've been able to look for 2024 at the care provided in 4 of the adult general hospitals across the trust. So what we saw sort of very quickly, very early on, and focused, the first set of numbers is our end of Q2 data. We'd seen quite a significant downturn in the percentage of patients who were having a daily assessment of hydration. So I guess just to give context, in 2022 at Wythenshawe, 98% of patients were having a daily assessment of hydration. At MRI, it was 89% of patients, and at North Manchester General, it was 47% of patients. So although initially We'd seen some improvement at North Manchester General, and that was, I think, following quite a focused piece of work in 2022. We then started to see, as I mentioned, we'd started to see a real downward trend in the data from the other sites. I think it's important to add that over the course of 22 to 23, as an organisation, we moved over to an EPR. So our individualised end-of-life care plan was transcribed not very well into an EPR system. And I think that probably does account for some of the documentation. However, it was then really important for us to triangulate some of that data. I'll come on to that in a second. I guess this next set of data, that sort of year-end data, thinking about the key indicators for NACEL for 2025, key indicator 2, this is the indicator here. So we thought we'd look at that in the context of 2024. And actually what we saw is that there's a huge percent of patients, those important to patients, who are not having any conversation regarding hydration. So we knew it was a real problem and probably multifactorial. So next slide, please. So as I mentioned, we felt it was really important to understand, is it just the assessment of hydration? Is it just the documentation of the assessment hydration? Or is there something more to it here? So again, looking at the bereavement survey, we've been able to put a really robust process in place at Manchester, and I've actually had more bereaved quality survey results than ever before. So actually this data was really important to us in this context. And again, as we can see, is that the what we saw in the case notes was also fairly similar to the experience of care by the bereaved as well. I guess probably what was fairly concerning to us was the staff element, in terms of actually what we had was exceptionally confident staff, or staff that they were reporting that they were exceptionally confident in having discussions regarding the assessment of hydration, and that disconnect really between care delivery and the experience of care that was being provided. So as an audit management group, which is a combination of palliative care colleagues from across the three main hospitals, which is Wythenshawe, North Manchester and MRI, we agreed that we needed to take this, even before the year end, on as an improvement piece of work. So what did we do? So next slide, please. Well, firstly, in an organisation this large, we really needed the engagement of our senior leaders. So each of those hospitals that I've just talked about sits within their own clinical group and has their own leadership structure. So we presented some of these interim results at each of those clinical group quality, safety and effectiveness committee to really get the engagement of the directors of nursing, medical directors, divisional colleagues as well, and get that agreement that actually this piece of work was vital. We then have an overarching end-of-life oversight committee, and again we took this through each clinical group end-of-life steering group to the oversight committee to get the engagement of our deputy chief nurse. And then we agreed to pull together a multi-professional group, which we established probably around May last year. And what I would say is it was overwhelming just how engaging our AHP colleagues were. So also as an organisation, we cover 4 community localities as well, which is all part of the same trust. So we were able to invite therapy colleagues from across the acute and community settings, and also palliative care and district nursing representation as well. So that group was established in May, and was comprised of nurses. It's chaired by myself. We've got speech and language, dietetic, medical, occupational therapy. I think we've actually got a physiotherapist in there too, district nurse and community matron. We've got our nutritional team and our nutritional specialist nurses involved in that group as well. So what did the group do? Next slide, please. So we set ourselves 4 key priorities, and we agreed that it would be a time specific and time defined working group. So it isn't something that we anticipate to roll on for years and years. And I think sustainability is something that is really important to recognise. And in an organisation as large as this one, we have to be able to respond to the live issues that there are. So the 4 priorities that we agreed were resources. What guidance is there for staff? What literature is there for patients and those important to them? We agreed a priority of education. So we wanted to scope the gaps, understand the level of knowledge and skills. So we completed a trust-wide training needs analysis. And when I say trust-wide, the trust does employ 28,000 staff. So we scoped the relevant staff groups to really try and get an understanding of where the gaps in knowledge were. We also focused on documentation. So yes, we do have an individualised plan of care in our EPR system. What I would say, it's not particularly user friendly. It's something that is called a flow sheet, and actually our medics don't tend to use flow sheets. So we also saw quite a disconnect between the documentation, particularly around end of life care, and who was documenting that. So it was predominantly left to nurses. So again, likewise, our therapists and other HPs were not really using the documentation that we have in our EPR system. And then multi-professional working. So we really wanted to focus on how we're making these decisions regarding hydration, and do people know where to go to for support. So what we've done since then, and I would very much say this work is very much a work in progress, as I'm sure anyone who works in a large organisation can testify, change takes a lot of time, and there are a lot of hoops to jump through, and issues to circumnavigate, and groups to get things approved through. So at the moment, we're working with our nutritional specialist nurses and our gastroenterology team on revising their nil by mouth guidance document, and we've now added a specific section in there about patients who are recognised to be dying, and the appropriateness of nil by mouth orders, and what suitable alternatives may be, where they can get advice, and signposting that advice to speech and language therapy, to dietetics, and to palliative care services. We've also developed a directory of resources. So in an organisation as large as this one, do people know where to get help from? So this is very much a directory of resources aimed for staff. So if you're a member of staff on a ward in North Manchester General Hospital, and you are worried about a patient who's got clinically assisted hydration, who's approaching the end of life, do you know who to turn to for some advice and some multi-professional support? And likewise, in that directory of resources, we've also got the same for if you're a district nurse out in central Manchester or out in Trafford, for example. So again, that is quite a big directory of resources, but it was really apparent that actually, even as one organisation, we as the professionals in the room didn't really know what services were available. So that was being really helpful to pull together, and that's available, or will be shortly available. We're just sort of fact checking everything on our intranet for staff, and will be part of a launch programme for these resources. We've also got a programme with our data team and our EPIC support team, and that's our EPR system, to revise the personalised plan of care, and to see how we can make best use of the resource, working with clinicians. So there's a separate working group specifically looking at that, which we've got acute clinicians involved in. Almost, how can we get you to the party of how would you, and how can we get you to use the appropriate individualised plan of care document, and how might that need to look? And we're also looking at, does the documentation meet the need? So are we actually making it clear about an assessment of hydration status? And then within our EPR resource, there's also, as well as the daily sort of assessment of holistic care, there's a separate comfort observation tool, which it replaces your standard set of observations and is more a visible set of observations in terms of the comfort of a patient. And actually, the hydration status falls into that, and that set of observations is taking a minimum of 4 hourly. So we've got, again, a separate IQP piece of work that the palliative care teams across the group are leading on, specifically looking at the how we can make best use of the comfort observation, how we can assign a score to some of these things, and actually then working with our hospital at night teams and our nurse clinicians to actually, if patients are scoring on a comfort observation in the same way they would a News 2 score, what is the out of hours response to that? And again, we're hoping that assessment of hydration will form part of that. We've also been able to engage our end of life care champions, and we've done quite bespoke sessions with them on the practicalities of providing alternatives to oral hydration. So whether that's been how to provide mouth care. We're currently working with our professional practice group on the use of subcutaneous fluids, and likewise that piece of work is then something that we're carrying out into our community setting, which is something that's previously not been possible. So there's a lot of work that's ongoing, and I think it's important to say key to even keeping this program of education, this program of work ongoing in the context of a very busy organisation, has been the oversight through our end of life steering group, the oversight through our end of life oversight committee, and the clinical group leadership engagement.
Thank you so much, Paula. Thank you. What an impressive piece of work, and particularly the level of attention that you've given to that scoping exercise and engagement with stakeholders, multi-professional. I think that is such a key part of any quality improvement work. And yeah, really interested and excited to see how the years go by and how things progress for you. But both case studies talking really nicely about how they've used NACEL data to support their quality improvement work. So I know that there's plenty of questions that have come up in the chat, and if you have any questions you'd like to raise, then please just raise your hand, and I'll just ask the team to help me manage with the hand raising. But Rosie, is there anything that's come up in the chat that you want to come to straight away?
I think Joy, so there's some questions about bereavement survey, but Joylyn's put the link of our tips and tricks about how to improve the response rates and our feedback from other teams. So I wonder whether if we focus on some of the questions about the hydration and nutrition questions to start with. So I think that there's a hand up now, and from David, I think.
Hi, good afternoon. My name's David Smith. I'm the lead for palliative care at Royal Brompton and Harefield Hospitals. One of the things that we do struggle with, and I'd be interested to know if others have the same problem, being a tertiary hospital, a lot of our end-of-life care takes part in intensive care unit with patients who are sedated and ventilated. And sometimes trying to carry out, for example, the case note audit and answer the questions accurately is challenging for us. And I just wonder whether other people had faced similar difficulties and how they'd address that, or if there can be any advice from the team there.
Anybody in the group that can answer David at all?
May I? Hi, David. Hello. I'm Mary Miller. I'm one of the consultants in palliative medicine based at Oxford, but also the clinical lead for the national audit. And yes, we have had one group approach us, the colleagues in Papworth, who likewise have a large percentage of people dying in their intensive care, and it does affect their nasal influence rather than affect their nasal results. So we did some work just thinking about looking at that group of people separately from other deaths in the hospital. I don't know if I addressed your question.
That's really helpful. I meet with the Papworth palliative care team quite regularly, so I'll go back and pick their brains as well.
Yeah, absolutely. Thank you. But in recognition that there are a variety of types of providers feeding into the national audit, acute, community providers, and indeed no two hospitals are alike. Thank you.
Thank you, Mary. If there's no other hands up, is there anything specific to hydration or any of the case studies in the chat box that we should come to? If not, then I would just like to pose a question to Paula and Anka. There are so many different competing priorities and loud shouting voices for quality improvement resource. I'm just interested to know how you have managed to keep the momentum going in your respective hospitals with your quality improvement work. Paula, if I come to you first.
I think it probably does come back to what you mentioned at the beginning, which is my role is quite a unique role. There aren't many heads of nursing for end of life and palliative care. So I think the answer to that is me, in that I'm fairly tenacious. And also I think as the chair of the group, being that I've been able to really influence keeping the momentum. You're right in that there are competing pressures. And I think what is really helpful for us in Manchester is we've got our own dedicated end of life care strategy, and actually this is something that we agreed at the beginning of, I guess, 24 to 25 as a key deliverable, because we think we'd already at that point by April started to get a feel as the auditors that actually there was a real issue here. So I think having that stakeholder engagement across the organisation has been really key. And also because I'm not in a clinical role, so I'm not being taken out of clinical time to do this, and that I guess has been some of the challenge, particularly when the same people who are involved in QI are coming out of small palliative care services. So I think my role has probably been key.
Thank you, Paula. And Anka, how about you? You spoke about leadership a little bit, but how do you manage to keep the momentum going for your quality improvement work?
Yeah, it's tricky. I think I didn't say we are well represented at trust induction for doctors and for nurses. We've got our regular nurses improvement days. We've got our regular teaching for junior doctors and oncology and ED and other departments. But there's so much we can talk about. There is crisis management and pain management and general cultural needs. So to have an in-depth discussion about hydration nutrition often doesn't find the space. So we found it really useful to have this parallel working group with, it's really about the people. Lucky to have very dedicated speech and language therapist and dietitian who kept it going. And then every time a new junior doctor starts, they had the momentum and they had the drive to carry on the next cycle. So it's a combination of using who's in your workforce to support that.
Thank you. I think I just saw Jonathan's hand go up.
Oh, hi there. My name's Jonathan. I'm the consultant nurse at the North Middlesex, working with Anka. Just to follow up on the point Anka made, I think finding ways to, and this takes time, and it can be really incremental and frustrating sometimes, to wait for the opportunity to get this kind of voice heard in an environment that isn't a specifically palliative end of life care environment, where we're waiting for the chance to speak their language, rather than asking teams to see things from our end of life point of view, particularly where speech therapy, dietetics become even more important to that point, so that questions like this begin to feel like everybody's concern rather than just a specialist concern.
Thank you, Jonathan. Mary?
Thank you. I think Rosie's shot up as well too, but thank you very much for the opportunity to ask a question. I'm interested in thinking about, was this your worst result, if that's the way to put it, or your most concerning result, or amongst the many things that you could have chosen from your NACEL data, what was it that made you choose these topics, if you just interested to know? Thank you.
You're asking asking me. Yeah. Yeah, so definitely 2019, that was the worst result. And we also had a low outcome for family involvement. So that's why it wasn't a surprise. It was what we had been feeling in our trusts. It's a big, very busy hospital with lots of stressors on staff. And so the soft bits, if you can call this soft bits, don't get first priority. And I think it's seen as a soft bit, the eating and drinking at the end of life. This fluid that will run or it will not run. That was slightly the approach at times. Let's put that. So we were aware that this was a problem, and then it was very clearly brought home to us and to any to our end of life care steering group that these were the main problems. Yeah.
And I think for ourselves in Manchester, what we saw was that it was a real stark change. So actually the position at the two biggest hospitals, you know, you're talking 98% and 89%, and then dropping into the 60s. So that massive shift. Yes, there was some improvement at North, but actually we were still sort of an outlier in terms of national comparison. So I think that was a key driver for us, and also as the audit squad that we called ourselves. So there was a group of 12 of us across the organisation, auditing a case a week to simply to get the numbers through, because we wanted our case notes to be reflective of the actual number of patients that die in the organisation. And each and every time we came back together each month to say how's it gone, we were all saying the same thing, that the assessment of hydration is something that we need to do something about. So I think it was bringing both of those things together for us.
Thank you so much. I can just see people are starting to leave. So if I can just make a final plea that if you haven't already filled in our evaluation, we would be so grateful if you could do so. It takes 2 minutes and it really helps drive what we do for our quality improvement webinars and the support that we are able to offer you. I will come back to questions. I just wanted to take you through some next steps. If I can go to the final slide, please. So as mentioned, if you haven't got access to the data and improvement tool to review your results, then please follow the links in the chat to access your login details and access data for your hospital. You can visit the quality improvement pages on the NACEL website with the following link that's up there. The next events that we are hosting, we have a drop-in session for the data and improvement tool, specifically for ICB colleagues who are starting to apply for login details, which is really great. They're taking place on the 24th and the 27th of March. If you know anyone or have any colleagues or are keen for your ICB to be seeing your data, please do send them the link and get them to sign up for that event. And we are also in May launching our first NACEL Improvement Huddle. This is different to the webinars. It's a more informal space, more discussion, and it will be taking the format of quality improvement coaching and talking about the quality improvement experience, obviously related to NACEL, and there will be a case study, but it won't be a PowerPoint presentation. It will be an open forum of discussion and much more responsive to what comes up in terms of the quality improvements, successes and challenges as you find them. And finally, please do just keep in touch with us. We're always really happy to receive emails and any questions that you may have, and we'll do our best to get back to you as quickly as we possibly can. And so if there aren't any further questions, I just wanted to ask Paula and Anka just one final piece of advice for your fellow colleagues if they are struggling to use NACEL data or they don't really know where to start, anything that you particularly would recommend or anything that you have found particularly helpful. Anka?
I mean, well, very quickly, I hate the amount of work that goes into it, but I love the process of auditing because it's a bit what the last person just said, you learn so much by seeing what you've actually recorded and what you haven't recorded and what you might have done but not recorded. And otherwise, what I like about the current NACEL data is what the ability to triangulate between case review and staff questionnaire, and we had very little response from the quality survey, unfortunately, but that's a beautiful opportunity.
Thank you, Anka. And Paula, any final words of advice at all?
Yeah, I think get to know your data. I think again, likewise, in quite a bespoke role, I've been able to really interrogate the data and have the time to do that. And I think you know, you're absolutely right in that the ability to triangulate the information, the information from the bereaved relatives has been so vital, particularly for us as an organisation. We had quite an inequity in terms of specialist palliative care access, and we've been able to use our NACEL results consistently for the previous round and then this round to get additional resource for specialist palliative care services, for education, for those sort of things. So so it's really important to get to know your data and have good friends in the audit department.
Jess, is it all right if I just quickly add something?
Of course, of course.
So we're collating a good practice compendium from some of the different examples that have been submitted from NACEL, and so that will be available soon. But I know in the chat there's lots of comments about how changes in to electronic systems and using EPR and changing from a paper individualised plan of care has made a difference to the quality of some of the assessments and information. If anyone would like to share that with us at the NACEL team, a little bit like the information that we've collated about how to improve your quality survey, or if it's that you'd like to share what EPR you use and your contact number, then we know that sort of facilitating these sorts of conversations between different people who use the same systems can be a really helpful way of making sure that we don't duplicate work when there's people that have either got known problems or they found some solutions that have been really effective. So it's slightly off-piste, but it's partly, I think, about some of the problems that we have noticed through the chat about how people have found some of their issues in these areas. So do get in touch with us as a team if that's something that us collating to help with the wider quality improvement work would be useful.
Thank you, Rosie. Is there any final questions?
Just in case Jess has frozen, I think thank you to everyone who's come today. I found it a really interesting session to hear the different contributions and to reflect on the NACEL data that we have about this, as we were just saying, from the different components of NACEL, and having that breadth of information is really helpful. And it's been so helpful to hear different examples of how people are doing this in practice, because I think that's what we're really trying to do with this quality improvement work, is help us all think about how to make a difference from the audit data itself. So thank you so much for coming and sharing your stories together. It's been really valuable. And thank you to everyone for coming. We hope that this will be something that you all feel inspired to go away and think about how you can make a difference in your organisation as well. Thank you.
Thank you. Bye.
Thanks, everyone. Bye.
Bye.
Bye-bye.
Thank you.